tonight's, if I might probably start, I think is important to say that tonight's webinar is very much around trying to translate the solutions that we've talked about over the last few weeks into solutions that really work in low and middle income countries. So it's a great honor to have Raman Kumar, who's actually done that, pushing against the tide, pushing against things. So I think we'll go, as we traditionally do, to Raman's lecture, and then please start to put questions into the chat. And Raman, when we've come back from the lecture, we'll ask you to give us some reflections, and then we'll ask some questions of you and start some discussions. So let me.
Hello, Namaste, good evening. My name is Dr. Raman Kumar, and I'm the president of the Academy of Family Physicians of India. I'm also the president of WONCA South Asia region. WONCA is the World Organization of Family Doctors. I'm also chief editor of a journal, Journal of Family Medicine and Primary Care. At the outset, I would like to thank WONCA Rural, the Working Party on Rural Education and Training, and TUFH, the Network Towards Unity for Health, for giving me this opportunity to speak and share my experience on how to establish family medicine in low and middle income countries. So I'm going to talk about establishing family medicine in low and middle income countries. I am based in New Delhi, India, and we have done some journey in India, and I'll be sharing that in due course of time, and which is contextual to our talk and discussion today. So as a part of the global leadership of WONCA, World Organization of Family Doctors, I had earlier opportunity to represent the Young Doctors Movement on WONCA World from 2013 to 15. And then now I represent the South Asian region on the WONCA board. And through this association, I had the opportunity to travel many parts of the world and learn about family medicine development across the world. And my interest, especially in, of course, the low-income countries and middle-income countries, the countries similar to India. And in 2018, I had the opportunity with the WONCA team to visit China, where we saw the massive interest and investment in the family medicine general practice academic programs. And similarly, when I went to visit Brazil, we saw similar enthusiasm towards family medicine. So I cannot give all examples from across world, but the talk I'm going to give is relevant and mostly based on the experience which we have in India. So what we are going to learn is what are the key determinants of status of family medicine in different parts of the world. What are the barriers to development of family medicine specialty or discipline in different geographical locations and nationalities, and how we can work as professionals through advocacy, activism, professional development, and how do we, in the special context of low and middle income country, we can help as professionals to develop this discipline and specialty. And then I will also share what we have done in India during past 1 decade, in 10 years or so, what we have achieved. And in my understanding, it is possible to make change in our respective countries in a shorter period of time. So now I'm going to talk about the status of family medicine, how and what are the determinants of different developmental stages of family medicine across globe. And this depends on the economic status of the country, political economy of the country, and how the health system is organized in that particular country, like it is publicly funded, privately funded, or it is mixed kind of arrangement for healthcare delivery system, because the status of family medicine varies according to that. Now, we also have to look what are the current health policies of the respective countries, how the public health system has been envisaged during past at least 50 years, whether it is comprehensive primary health care or it is selective primary care in the context of the low and developing countries, low income and middle income countries, we see that largely these countries have their public health system organized with the philosophy of selective primary care, where we have national health programs which are disease focused, and the comprehensive health care provided by the family physicians, general practitioners, is not valued that much. And also, it is important to look at the financial framework of the health system, because how insurance is placed, and how, whether it is publicly funded, privately funded, or out of pocket, these are all the factors which determine the status of family medicine in any given country. And medical education system is important because all the ideas which evolve among the professionals, and how professionals develop and how they are trained, and they are engaged into the health system, that all originates from the medical education systems. And then we have to be mindful how the career pathways of the medical professional is designed. So what happens when one completes the undergraduate or the graduate program, and what are the options to specialize or to move into the health system afterwards. And most importantly, from the professional's perspective, it is important that what are the arrangements for the income and employment opportunities for the family physicians, or as a career option. Because if that is not sufficient enough, if that is not defined enough, it is difficult to attract good talent and new medical graduates into family medicine discipline. So I'm also just using few graphics to explain. It is true in many parts of the world, and this I'm talking from my own experience in my own country, India, where we have medical education system is fragmented into human organs and systems. And this originates from the medical schools and colleges itself, where we have undergraduates, MBBS doctors trained through different specialties and departments in the mostly in the hospital tertiary care setting, and they hardly have any exposure and experience in the community based facilities. And community based facilities, like in India, are not often accredited. Were accredited, of course. Now we are changing recently for medical education. So how the education system looks at human health is fundamental to how what intervention we need to do in the context of developing and establishing the discipline. And hierarchy of service providers, how within the profession different specialties, specialists, subspecialties are organized. And many times the subspecialties, specialists have more power within the professional domain, academic domain, in the domain of research, and which is often a challenge and barrier towards developing and establishing family medicine. Many times a single career pathway is visible or available to medical graduates, which is a specialist pathway. You only can progress your career if you choose a specialist residency, and afterwards you work like a consultant or a specialist when you acquire this specialist qualification. And not often medical graduates are exposed to the idea of the generalist training and the generalist career pathway, and which is I think true for across all nationalities when we look at the low and middle income countries. So for the medical students and medical doctors, we often blame them for not entering into a community based vocation. Many times they do not are attractive enough to rural career pathways, but that largely originates from the curriculum, how they have been trained, and how do they perceive the profession and professional goals from their medical schools. How do we change this whole perception or the challenges? And to me, from our experience, I think working in an organized way is most important. And many parts of the world, we do not have strong family medicine associations or academies or colleges, which are the key tool to make progress in any country, because they are the one who drive the whole momentum of development or advocacy and professional development. So These national organizations are responsible for organizing national and regional conferences and academic events. They also organize CMEs and CPDs, continuous professional development activities, so that the medical graduates or the practitioners get a continuous support. And they also organize advocacy meets. And in terms of from our experience in India, I would call it activism. Just normal professional activity is not sufficient many times, because there is a lag which has to be covered. There is a distance which has to be traveled. So I would call upon the professionals to do some kind of activism in the domains of professional education and the research part, all, because we have to address all these three domains: professional, academic, and research, whatever we are efforts we are taking for establishing family medicine. Apart from this, political engagement of the is very important. Developing relationship with the political system of the country is very important, because it is the politicians who make decisions for the country. They are the one who influence policies, policy making. Additionally, we can also think about legal activism. There are many ways. Health is a human rights. So in terms of human right violation, if any system or in a state or a health system is not able to cope up or to meet the needs of the public health, it is of course is a legal issue. So this pathway can also be adopted. And lastly, I mentioned the legislative approach. So by legislative approach, we can approach to our political representatives, bureaucrats, all stakeholders, and try to bring change into the policies directly. We can influence them. And many times we can also concurrently work on the developments of laws, regulations, and acts which have a direct uh, influence on the health status of the people of the any country. So now I will briefly go through how it has evolved in India, and what was our experience. And I cannot talk on the behalf of all countries, but if I share my experience and we can relate this experience to how it can be done in many other parts of the world. So the regulatory mechanism and evolution of academic family medicine, I have just shared this slide. And the Indian Medical Council Act, the regulator, was established in 1956, and family medicine qualification is recognized since 1983. So if you look at time, it has been almost 40 years since family medicine course, and is a recognized discipline. But we did not have sufficient number of training positions, and it was rather insignificant, because we had only few training sites and locations which were formally training family physician. And I'm one of the first generation family medicine trained person who is trained through residency training. So in spite of having a recognized course, we were not able to make any progress because of various challenges which I mentioned earlier. But fortunately, in 2002, our national health policies articulated that family medicine should be an important area of human resource intervention as far as the development of health system is concerned. Taking a clue from there, a qualification Diplomat National Board Family Medicine was launched, and the seats are varied, but currently there are around 15 training positions which train around 200 trained family physicians. By default, we have a system where after doing your undergraduate or MBBS course, you can enroll in the council or in your local regulator and become a practicing family physician. But practically that does not happen, because all of these new young doctors, new graduates want to become specialist doctors. So in spite of we having large number of medical graduates coming out every year, not many of them in the recent decades were trying, or we are wanting to become family physicians or practicing family doctors. So when I completed my residency in 2010, we had a challenge that how do we take forward, because we did not have any defined career pathway. So in 2010, we founded Academy of Family Physicians of India. Although we had other GP associations in past, we had two other major GP associations, but they were more into doing CMEs for the GPs, and mostly these CMEs and CPDs were conducted by the specialists for the GPs, and the academic development of family medicine was not taking place. So we founded Academy of Family Physician of India in 2010, and during one of the Wonka conferences in Mumbai, in South Asia Conference of Wonka, in 2012, we launched our journal, Journal of Family Medicine and Primary Care, because we recognize early, because if you want to be recognized and valued and respected as a discipline or a distinct specialty, you must have all the forums and systems which make you a distinct entity as compared to other specialties. In India, we did not have a peer-reviewed family medicine journal, so we founded a journal which is called Journal of Family Medicine and Primary Care. It is now is in PubMed Central, and it is widely read and referred to in India. Currently, we are getting around 300 submissions every month. About 30 to 40% of them are international. And 2013, we organized our first national conference. So you can imagine there was a course training which was recognized since 1983, and till 2013 there was no academic family medicine conference, and we called it family medicine and primary care because because of the terminology of the confusion of family medicine. Many times it is difficult to emphasize with the policy makers, and we deliberately added this the context of primary care to our conferences, to our journal, because we wanted to emphasize the importance of family medicine with respect to the healthcare delivery system, especially in the context of primary care. And with this conference, we also organized a national consultation of family medicine program, which was through our engagement, which was organized by the Ministry of Health, Government of India. And we invited experts from all over world, from wherever we could get experts. We brought them to Delhi, and we had extensive consultations and discussions, and we came up with a consultation report, which was then shared to our regulators, to our ministry, and also to professionals. It was also published in our journal. So, as an outcome, we were able to maintain a momentum, and family medicine was again emphasized our national health policy, which was announced in 2017. And family medicine was again mentioned in this policy. But somehow, in spite of being in policy in 2002, 2017, it has been almost 2 decades now, things were not moving, but we continued to push for it. In 2018, as many of you are aware, and many of you probably would have attended, we organized the Wonka World Rural Health Conference in New Delhi. And it was a great movement in terms of advocacy, because we were able to engage Government of India again, Ministry of Health, and we were able to reach out to the highest officers of Government of India. We invited the Vice President of India, Health Minister of India, and all top policy makers attended this conference. In 2018, again, we put a formal petition to the Prime Minister's office. And since it was almost 2 decades and things were not moving, as I have talked earlier about the legal activism, we put in public interest litigation with respect to family medicine discipline, why it is not being implemented by regulators and why it is being blocked, we assume, by the specialist doctors. And in spite of being, within the national health policy for such a long duration, why its implementation is not happening and it is taking so much of time. So we went to the Supreme Court of India, and the Supreme Court directed us that since it was a policy matter, and court cannot give a direct direction on the government, because policy is an intent of government. Policy is not binding on the courts through courts. So although we had discipline being repeatedly discussed and recommended through policy recommendations of the government itself, it was not happening. So when we went to the court asked us to approach on the order of court to the to our regulator, Medical Council of India, as well as the Ministry of Health, again with this court order. And we went again in the background of this Supreme Court order that why it is not happening. So in 2009, things started bit changing. It was only last year, and a family medicine specialty board was constituted. by National Board of Examination, which is one of the medical regulators in India under Ministry of Health and Family Welfare. And uh, our Academy of Family Physicians of India, was invited to this. And simultaneously, we got a reply from our Prime Minister's office. He said, and in that letter, it was assured to us that although it has been in policy, but now we want to make it part of an act. So our National Medical Regulator Act, which is called Medical Council of India Act, was scrapped. And 2019, a new regulator was formed, which is called National Medical Commission. And this act was passed in our parliament. And as part of this act, now this commission has been mandated to promote family medicine and primary care at the undergraduate, postgraduate levels, and also throughout, give them a proper professional career pathway. So now this act is a binding, and we expect, we have a huge medical education system in India. It is perhaps one of the largest in the world. We have more than 500 medical colleges or schools in India. We are currently producing around 75,000 medical graduates a year, but still only negligible number of doctors through a formal education system were going into the vocation of family physicians. And now, with the help of this National Medical Commission Act, I'm sure this discipline will be made mandatory across all medical schools. Earlier, we did not have a mandatory department of family medicine, and we have a flagship program of Prime Minister, which is called All India Institute of Medical Sciences. And there are plans of starting this. Earlier, there was one institute only in New Delhi, but now it is being rolled out across all state capitals. And all India Institute of Medical Sciences have Department of Family Medicine and Community Medicine. So it is being established through a series of advocacy and acts of activism. So I'll just rush through pictorial journey of what we did in India. So this is our logo, Academy of Family Physicians of India, and you see 9 rings which represent the 9 principles of family medicine, and Academic Association of Residency Trained Family Physicians of India. This is what we are trying to implement in India. And this is from our first National Health Conference 2013, which was attended by the Health Secretary, Government of India, and the all top regulators of medical education and healthcare delivery systems in India. And simultaneously, we convened a national consultation of family medicine, which was, of course, hosted by Ministry of Health and Family Welfare. And we invited international experts from all over the world. And we made recommendations to the Government of India. And after 2 years, we were able to engage the health minister, the political figure. He came to the second National Conference of Family Medicine and Primary Care. And this helped us to push forward the agenda of family medicine into the next national health policy, which came in 2017. This is the cover of one of our journal issues. And you see Taj Mahal and this infographics on the cover. A way to brand family medicine in an attractive way, which attracts talents from young doctors from the medical schools. And we use this journal as an advocacy tool. And whenever we meet high officials in India, wherever we go, we present this journal issues as a dissemination about the information of this specialty. We present it to all higher authorities whenever, and we disseminate it in public and social media also. We also do some public engagement activities, and this is one of the social events we organize, Run for Family Medicine, where we invited one of the Olympians to our event. And the idea was to engage general public and make them aware about the family medicine, family physicians role in the society. And rebranding and repackaging of the image of family medicine is most important in that context. Many times people have perception about the low quality or low level of academics about family medicine and primary care. So whatever we do in our graphics, in our social media disseminations, conferences, on our website, in our journals, we try to make standard statements through images, infographics, and content. And we also have been trying to develop young leaders for family medicine. This is one of our advocacy posters, 100 Faces of Family Medicine. These are all young doctors from across India whom we are grooming into leaders, and many of them have become state chapters presidents and regional presidents, and many of them are now organizing state level events, even national events in the respective areas, because India is a very big country. We have 30 states and 700 districts, and our population, we all know, is close to 1.3 billion. And we always try to engage with the International Association of Family Doctors, which is WONCA, World Organization of Family Doctors, because it helps to keep ourselves aligned with the international global health developments. Here you can see our world president, Donald Lee, with Director General of WHO, and we have a MOU signed between WHO and WONCA. And this helps us to keep family medicine in the flow internationally, nationally, and within states. And this is one of our photographs of inauguration from the World Rural Health Conference 2018, where we had our Health Minister of India government and Vice President of India. You can see Professor Dr. John Wynne Jones, then chair of the Working Party on Rural Health, WONCA. And these all have been great help in advocating and coming to where we are now, especially in terms of the act that I talked earlier. And this was again a report which we collated during this conference, strengthening primary health care for rural India. And these activities have helped us tremendously in establishing the idea of family medicine in our health system. So this is all from my experience, and I can say that with determination, with a vision, we can definitely establish family medicine, primary care in any part of the world. And this is what I have shared from my own experience in India. I hope this is relevant and contextual to many parts of the world. Thank you very much for this opportunity. Thank you, WONCA Rural. Thank you, TUFH. Thank you all. Thanks a lot.
Hi, Bruce.
Sorry, I'm on mute. Thanks, Raman. That was really terrific. And it was, I'll bring my video on too. It was great to hear of your progress. You've done an amazing job in bringing family medicine forward. It's such a long process. We found that in Australia. I think people find it all around the world. It takes lots of effort, lots of persistence. We've had some questions come up around the brain drain, if you like, the movement of people around and the issues that brings up. But before we get to that, where do you think you're up to now? What's the next steps here with family medicine? It's still, you've made enormous progress, but it's trying to find the benefit for patients and the benefit for doctors in going into this. You've still got some areas of government that want to just send untrained doctors out to rural areas and without any further qualifications. What do you see as your next steps, and what are the big challenges coming up? Thanks, mate.
Since we recorded these presentations, we have revised the whole curriculum of family medicine in India. I am the convener of the Family Medicine Specialist Board, and we have senior doctors working with us. And we, apart from the 3-year program, residency program, the new development is that we are having also now 2-year diploma program. So there is a huge interest because we have large number of medical graduates, and governments would want them to be engaged with the health system. Uh, uh, and to do that, I mean, especially in the context of family physicians, the other challenge is and was earlier is that there were no employment in the public sector for the trained family physicians. I mean, residency trained family physicians were not employed as a specialist. So in principle, we have a standard called Public Health Standards of India, and uh, revisions are made. The last one was developed in 2012. In that standards within the human resource context, family medicine specialists were not mentioned. No requirement was there. So largely the state organizations, the central government organizations did not recruit family physicians into the health system. But now these standards have been revised. It's only a matter of time it will be made public. And in these standards, we have pushed through our advocacy, and government had agreed to designate family medicine specialists at community health centers and up to district hospitals. So we will have formal employment within the government systems, which was not there earlier. For family physician, the only option was to work on their own in solo practices in private setting. So that is, being steered through. Uh, uh, and now we have reached a level where, large number of trained family medicine specialists or physicians are now contributing to development. Earlier, we were borrowing faculty, examiners, curriculum writers from other disciplines. Like when I, appeared in my final qualifying examination, my thesis guide was a neurologist, and I was assessed by a surgeon, a OBG, internist, and there was not single family physicians in my final assessment examination for my residency training program. So now this all has changed. We are the one who are writing curriculum. We are the one who are writing the OSCE stations. We are the one who are conducting the CMEs programs for our colleagues. So this has all changed. So but since as I said, we are a very large country, and it's a complex government system because some powers are with the central government, some powers with the state or provincial governments. So state and provincial governments also have to make respective amendments into their own framework of healthcare delivery system. Few states are very progressive, provinces are very progressive, like Kerala and Tamil Nadu, and especially in the states in the southern part of the India. But the progress is slower in the northern part. But we hope that we will catch up. But in coming 5 to 10 years, we will see the impact of what has been done recently.
Thanks, Raman. And we might have lost you there for a moment, but I think that it just shows you how long this takes. I think in getting the progress that that Raman's done there. I think getting the government to mandate family practice within their institutions really makes an enormous difference. We've got Radan talk about. Well, might wait for Raman to come back about what it takes to get their own board and the other things that happen there. Not sure if Raman's back again. Excellent. Raman, we've got a question from Radan in Algeria just about what did it take to have externally qualified family doctor trainers to create your own board. So I think you just talked about the fact that actually having family doctors examining family doctors to get that board structure, to get the government on side to employ family doctors in government areas. So many things that you need to do. Did you want to talk just say a little bit more about that? You're on mute. There we go.
Yeah. sorry, could you just repeat again what exactly was the
Yeah,
question? So
just
because I was
the
disconnected.
I suppose the key points in getting um, board recognition, the key points in getting enough faculty together to be able to examine family medicine, rural doctors by rural doctors, and we've also got one here from Marjorie you might like to move on to, is also about the public and private. You've talked about, actually now having some incentives to get doctors to work with qualifications in public work. Thanks, Ron.
Okay. So, as I said, things have improved largely recently, but we have a long distance to travel. We are largely outright a private health system. Although we have a very strong public health and government system, but largely the movers and shakers are from the private sector. So, and mostly, recently there is a public health program for the poor people. There is a coverage of 500,000 Indian currency rupees, and anybody can get treatment in any hospital, government or private. But earlier, the thing was different, and people were mostly dependent on out-of-pocket expenses for their own health and treatment. So in that scenario, it was all dependent on the market, and this would definitely change as I said, in coming 5 to 10 years, and more and more doctors. Our hospitals are saturated. Earlier I was also asked about brain drain and Indian doctors going into developed economies. Uh, to be frank, that is not a concern for us anymore now. I mean, it was 20 years back or 30 years back. But if you look our numbers in 2010, we were producing 25,000 MBBS doctors. And now 2020, we are producing around 75. And soon this number will be touching to 100,000 MBBS doctors a year. So number of doctors is not a problem for us. If even thousands of doctors move out of India, it does not make any impact back here. Our challenge is how do we distribute our own doctors within the Indian context, how to reach out to the underserved areas, and how do we strengthen these processes? How do we, strengthen the career pathways, which have started to build up. It's just onset of this thing, and how do we keep our doctors in place where it is difficult to. So when I talked about diploma programs, which is 2-year programs, it is largely intended to strengthen and support the doctors who are working in the rural and community setting, because this would be an additional qualification, and they would be given preference for this kind of training programs, so that they get a career pathway and progress on what they are doing, and their work as as professional and as a vocation is recognized or strengthened. So I see already large number of MBBS doctors are working, and this diploma program is to strengthen their professional development in their own context and setting. And as I talked in our curriculum, earlier it was all divided into disciplines. So family medicine was meant to be, a compilation of, or rotation, just rotation of, internal medicine, OBG, pediatrics. It was all scattered and fragmented. But now we have made it whole person care, comprehensive care, and also we have within our curriculum, we have also defined the career pathways, and we have emphasized on the rural training as rural generalists within the DNB family medicine program itself. So rural practice was talked a lot, rural health was talked a lot,
Looks like we might have lost Raman again. I know what the power can be like sometimes in India. So while he's coming back, do we have any experience from other countries about where you're at and what challenges you might like to talk about? and any thoughts that others might give to it.
When we came into this part of
Yeah,
rural journalist.
you're back on there, Raman. We
Yeah,
just
Raman,
lost you for a moment. Yep. We've got you again, Raman. Sorry, we lost you for a moment.
That is it. So largely, I mean, things are moving towards betterment, but there would always be challenges, and we will try to overcome them.
Thanks. We've got a couple of comments. Marjorie's made a comment. Marjorie, Jerry, Declan, any of you, or Al Hadi, would you like to make a comment, talk about your particular circumstance, or Hani,
Yes.
with respect to Egypt? I noticed you're on off mute there. Would you like to talk about Egypt?
Yes, in Egypt, the authority do for equality of care by legalization. After the internship, each doctor should experience and should work in rural and village for 1 year at least, 12 months. After the year of internship, any doctor working in the Ministry of Health have by law to spend 1 year in rural and remote areas. When he reached these areas, he found a well-prepared staff to train him and to practice, because it is early years in his practice. So he is going to work under supervision in the first year after internship. The alternative to him is to do military service. Secondly, any doctor in Ministry of Health in Egypt, after obtaining the postgraduate degree, the master degree, or the doctorate, or whatsoever, should spend at least 6 months in rural and village to cover in any deficiency of a specialist in these areas. And actually, in my opinion, to work in an area of need is very palatable, is very motivating to the doctor. And I am so happy to see many systems in, for example, in Australia, the doctor feels that he is not alone. He works under supervision. He is in contact with the hospitals, with the specialists in hospitals. So feeling that he is not alone, give him confidence, give him to feel that he is competent and confidence, which is very important. And also another point I would like to enlighten is that the equality of medicine is the responsibility of the doctor himself, because medicine is ever changing. Medicine is so variable, so enormous, so wide, so great. So the doctor should always do continuous professional development by all ways, whether by webinar, seminar, conference, staff around, and so on, because it is a matter of responsibility and a matter of honesty also. Thank you.
Thanks, Hani. I think this raises an important point, and that's about we like to see young doctors coming out to rural areas, but there's the risk sometimes that they will go out and be unsupported and unsupervised. It can be a very growing experience, or it can be a very destroying experience that can make them go back to the city. And I know, Raman, you've had a lot of interesting issues with very untrained doctors out in rural areas, and the issues that there are with that. I think we've seen a shift towards saying we need training in rural practice. Last video conference we had, last webinar we had, there was a lot of discussion on the ones before about the need for good training out in rural areas and supporting the doctors out there to be the trainers, to be the professors, to be the ones that actually teach family medicine and teach rural generalism to those new doctors. I might just ask you, Raman, for a comment on that, and then I notice El Hardy and a few others are keen to speak. So, Raman,
Okay.
Raman, did you want to say something first?
Challenges in a diverse country like ours is difficult terrain. Earlier, a lot of issue related to infrastructure and cultural diversity and differences. How people live in rural areas, and if you go to rural India, many places you'll see that life has not changed in last several centuries. Where if you go to cities, the things are rapidly changing. Some of the places are rapidly urbanized and modernized, but many places are traveling. It's like traveling in time. So, and medical education system at most places is urban, large, tertiary care hospitals. So training someone, even if they are from rural backgrounds, into systems which are outright designed to cater to urban population, we do not train them enough, as doctors or care providers for the rural areas.
Yes.
So
Yeah,
I mean, that is a big challenge we are having. So in spite of having big medical schools, institutions, they are not fit for training to the rural generalist or rural doctors.
Yeah, it's that need for training by rural in rural, that and of high quality. El Hardy, did you want to say something?
Okay. Good time, everyone. I'm really enjoy this series of webinars, and especially of today presentation of Dr. Raman. Thank you very much for the amazing presentation. I want to reflect what actually the situation now in Sudan regarding family medicine practitioners. In Sudan, we have three types of family medicine practitioners. Firstly, we have MD in family medicine from Sudan Medical Specialization Board. The medical doctor will award MD degree after comprehensive structure program in Sudan Medical Specialization Board, and after that they will be a part of the health systems. Also, we have two universities, University of Jazeera, I think, and other university. They also award master in family medicine after structure also program of 2 years. And after that, they will award them master degree. And if they want to continue for MD, they can continue on Sudan Medical Specialization Board. Also, we have another type of practitioners. These are medical officers. After they finish the intern program, they posted in rural area as a medical doctor and stay there for long time. I think 5 to 10 for more than this period, and work there as general practitioner in the rural hospital. And now these types of professional medical professional is very important in delivering family medicine in Sudan, and even they are more important rather than the than those who awarded MD. MD because who awarded MD in family medicine in Sudan, they immigrate after a short period of experience in Sudan to Arab Gulf or other area, and so there will be no available to the health system in Sudan. But the medical officer they stay for long times there and in the rural area, and they are known and they are expert. I think my advice to Ministry of Health in Sudan, if they want to establish a strong health system, is to uptake these medical officers, stay in the rural hospitals, they uptake them in distance or training, whatever, in trainings to award them master degree, and they can continue from their work of place, they continue to also to award MD in family medicine, and by this you guarantee 5 to 10 days to fund to 10 years of working there in the rural area. We have, I think, two problems or two obstacles. One is the immigration of the health professional after trainings. Most of them immigrate from Sudan to Arab Gulf, including myself. Now I am immigrant after experience because of financial issue and some logistic issue with that. And I think we need to work very closely with the international agent like WHO and WONCA for trainings for the trainers and training to obtain training for the family physician and general practitioners for more improvement and for more commitment for rural health. Thank you very much. Thank you.
Thanks very much. Al-Hadi, you bring up a really important point that sometimes the doctors who want to stay in rural areas are worth investing in to raise their skills rather than trying to necessarily attract people from cities who already have those skills but have no intention or no want to go to rural areas. So it's an interesting dilemma. I notice a few people were I'm muting a bit there. Did Ewan, did you want to make any comments? You made a few comments on here, and then we might go to Joyce. I know Joyce has made some good contributions on our previous ones, and on this particular issue of family medicine, we might go to you. Ewan?
Yeah, thanks, Bruce. Look, I fondly remember going to New Delhi, and your talk tonight's really just reinforced how much hard work you've put in and your colleagues have done over 20 years. The other thing is how similar the story is, and even now in our own country, we're struggling to convince our junior doctors that they might choose a career in rural medicine. The College of Rural Medicine has really captured their imagination through rural generalism, but we still fundamentally have a problem with primary care. And I think from hearing your talk tonight, I've heard a few extra little things that we need to look at and are applicable to a developed country as much as India. And thank you very much for your presentation.
Ewan, were there particular things that you wanted to highlight that you'd learned that were kind of little pearls from that?
Look, I think probably it's important to I guess select the right people, but really foster a culture of professionalism. And you spoke about the importance of research, the importance of having a recognised discipline and a curriculum, and doctors, GPs, rural generalists, examining rural generalists and examining GPs, creating that professional identity and a meaningful career. And I think that really came through very strongly. But also the significant and continuing need to engage with the political people within the country, and that's so important.
Others want to make a few comments. I'll ask Raman for his replies to some of those. Can we have people, maybe some who haven't spoken before? Is there someone who hasn't spoken before? I see we've got some lovely new members, Sheba, Rabaya, Manjunath. I've got to get all these right. Abalo. Would any of you like to share your experiences? I think Zakur's off mute. Zakur, are you there? Would you like to say anything about? You've done a lot of this recently from in primary healthcare in Bangladesh. What's your progress, and what do you think is important?
Thanks, Bruce. Finally, I want to thank Dr. Raman Kumar. He's a very good leader and actually very good speaker. So he did a lot in India. Actually, the situation is more like in India and Bangladesh and like Pakistan, Nepal, and Sri Lanka, more or less same. But we are still struggling in Bangladesh. But some improvement here around the conference, because already government decided and gazetted all young doctors should work in a rural place at least 2 years. It's mandatory. And 15 days internship training. No, it's to improve still, but 15 days internship in rural placing is a short victory. We hope so. In family medicine, people previously has not endorsed, not recognized. So that's where young people are not coming by their choice. But nowadays they knows it. You know, the Robaya and the Mushfiqun, they are very young medical student, but still they are interested in rural areas. They are our incoming leader. One of Mushfiqun is the Assistant Statistical Secretary of Primary Care Rural Health in a rural medical college unit. So people are coming. We need some time, but our people have not so much time because they are struggling for their health actually. But policymaker and we should not avoid all these things. So the improvement is going on, and I'm hopeful. And actually, like Raman, we independent in 71. So we are already celebrating 50 years of our celebration. But so many improvement in health as well. You know, we are in vaccine. We are done a lot, and in statistics of maternal mortality, infant mortality through the country is very good around South Asian country, and so improvement is going on, and I am hopeful. And the conference and you people are our ambassador, so people are know better from this, and we are waiting for a closing ceremony and some recommendation and declaration for our government and policymaker. So for that, and I my request is all of you to give some input for our resolution or declaration. So everybody please comment and help us. So thank you all for your gracious presence and comments. Thanks, Ramon, and thanks, Bruce. Now,
thanks, Zakur. Anyone else got any experiences they'd like to share about family medicine in their countries? Jerry, you're off mute. You want to say something?
Thanks, Bruce. I was really fascinated once again with the wonderful presentation. I really appreciated what was said, and I think it must be a bit like a cake. You need a lot of ingredients to really make a good cake, to make a good product. And I think that Raman has really outlined very much all the bits and pieces that's needed, and also a good political will and a strong lobby and a good organization to push that. And he has done tremendous work, and certainly it's very admirable, the progress that has been made. But again, a theme that has been spoken about, somebody needs to get up and do something. And if somebody doesn't, well, nothing is done. And I think today is a very good example of how somebody can do so much, and how we all, it's up to ourselves and our own countries to do what we can. It's most interesting about the brain drain. We have that too. People like to go to other countries, beautiful countries like Australia, for instance, which has beautiful beaches and all of that, and offers great opportunity. But that's because of maybe lack of opportunity in our own country, and lack of investment maybe by government in rural health, in generalist health in particular. But I just was most interested in the whole presentation, and it makes me really realize the importance of that there are a lot of things required, not least a strong organization which can push government to put the rural agenda up high there, and the resources more important to go with it. Roger Strasser's paper, I'm fascinated with his paper, Reimagining, the World Bank paper. There's so much in that about the Canadian model and Australian model, and how we need a new model really, and it has been imposed really by what has gone on before, the models that are there from the medical school down. So as was talked about, immersion in rural areas, but all of that needs to happen. But it does take a system to put the people in the rural areas to be immersed or whatever. I think Canadian Roger Strauss's model is so clear on all of that, and what has happened in Australia as well and elsewhere. So there's so much involved really, and I just would like to again just to say how much I enjoyed listening to the Indian experience and how fantastic work that is being done, and I wish them well with it in the future. Thank you.
Thanks, Jerry. Did you've got a fairly strong college, you've got a fairly strong health system. If you could change one thing in Ireland to make things better for general practice and rural practice at the moment, what do you think is the missing ingredient there at the moment that you want to change, having been in these webinars?
Thanks, Bruce, for asking that. Absolutely, it is putting rural very much on the agenda, but it comes from us as well. We need a good, strong research base in rural practice in Ireland. We really don't have it. Like, Ireland is a rural country, so we're a victim in that regard, that it is already a rural country to a great extent, and we have a wonderful Irish College of General Practitioners, but we need a strong rural organisation as well that is academically based, and that's why we are trying to build up our academic base, where practitioners like myself have so much experience. We would love to be contributing to research, more to research. So we need really to get grounded on that we need to align ourselves, and we are doing that with the University of Limerick as much as we can, to try and partner. And it is partnership, and Roger Strasser talks so much about partnership. It is about partnership, and it's about equal partnership. So we went to Albuquerque as equal partners with the Irish College of General Practitioners, the University of Limerick, to host WONCA 2022. And that was in a partnership, equal partnership mode, and that works. And that worked for us, and thanks to you, Bruce, and everybody that was there in Albuquerque, we are hosting that conference. But that was a major step for us. And we intended to have some research even for that conference, but because of COVID and so on, we're trying to get rural research fellows to work with us that would be funded by the Irish government through the Irish College of General Practitioners, and have the expertise of an academic body at our behest as an equal partner as well. So it's about, as proper, creating partnerships locally with the centres of excellence, or so-called centres of excellence, with the academic basis that can give us what we're missing. We need to put the rural agenda on the map, and the only way we're going to do that is by strong research, which will prove, evidence proved, of our needs, the needs of the people, and that is based on the needs of the area, the needs of the local area, that we can put down in pen and paper through the journal, which is so important, which was talked about today as well, that we can portray what are the deficiencies, what we need to do to fill those deficiencies, and we can do that best by research in association with our equal partners in the academic institution and in the bodies, and having a strong rural organisation to push at government level as well. Thank you.
Thanks, Jerry. I think Paul said last week about nothing about us without us. And I think that's a really important thing too, that the universities need to not be just looking at us like specimens under a microscope, but they need to be out in the petri dish. They need to be out in the rural areas and be part of the solution, not just a distant observer. Raman, I know you had quite some interest, and you have some very good universities in India who contributed to the international panel at the conference. I know you've got one or two really outstanding universities. How have you gone with getting family medicine as part of the universities, and the universities actually as part of family medicine? Have you managed to get them to go out to the rural areas and recognise those doctors in those areas as teachers?
We have a new pattern of, I'm not sure how it happens, but in many parts of India, the medical schools are being affiliated to exclusive health sciences universities. I mean, there are universities which are just medical schools. I mean, hundreds of, for example, there is one university for all medical schools in Karnataka province or state of India. And after our rural conference, we had our next national conference in Bangalore, which is in Karnataka province of India. And we invited the vice chancellor of this health sciences university. And he got so impressed with the demand and need, and seeing the young doctors in the conference and the environment of the conference, the level of discussions, scientific content of the conference, that he has become a very strong supporter. I mean, people realize, a lot of people, our experts at the top level know this is required, but it is responsibility. The responsibility lies on us. I mean, how do we reach out to them? And we have to formulate solutions for them also. So one of the universities, for example, in Karnataka province of India, which controls hundreds of medical schools in that particular province, the top official vice chancellors and all have agreed to establish locally within Karnataka family medicine programs in the mainstream medical education system. So that is happening. And of course, as I talked, we have All India Institute of Medical Sciences. Each institute is a university in itself. It's an autonomous university. And all these new All India institutes have Department of Family Medicine. And only a few days back, I was invited to All India Institute Hyderabad, which is in Telangana province of India, to address the first year MBBS students. And I challenge the whole notion of conventional medical education system that is being imparted, and try to talk about generalism, rural medicine, and solutions we can find, and also how we can develop new future. I mean, we all are worried about what will happen in future to family practice, general practice, rural practice, but it is up to us to create new future. And we have to be creative, and we just don't have to be responsive. We have to reach out outright, creating the new things. So unless we create future for general practice, future for family medicine, future for rural generalism, there will be no future. I mean, just worrying about it is not sufficient. So I mean, that we are trying, and that is happening, but to feel the impact, as I said, it will take another 5 years or 1 decade, 10 years, but definitely that is on the way. It's not because of sole efforts of ours. I must be, humble in saying so. It's not because of what we are doing or I am doing. It's because it is the need of the people. We have such a huge population, 1.3 billion population, so much of equity issues and all, and unless we change in that way, we cannot. It is in the interest of the political system also to address the way we are advocating. It is not because why we are saying, it is because largely it is required for the people of India. So we have to align the political interest with the interest of the people, and the responsibility lies with us to create future.
Thanks, Raman. It sounds like you're moving away from very inward-looking medical schools to schools of medicine within other faculties, working with other teams, and also, as we talked about last week, I think the whole business about all these people in rural areas are voters. They're people who have influence on politicians, and we need to harness that influence. I notice we've got a couple of very specific questions, and I don't want to miss those, but there's some stuff here about from Austin about vaccination policy, and from Marjorie about telemedicine, and what's the benefits of having telemedicine? What's the risks of having telemedicine? I mean, India is one of the IT hubs of the world. It's one of the places where everything happens, whether it's call centers or telemedicine. There's been some great innovations. What do you think? Is that going to help family medicine? It can help it. It can hinder it. What do you see as that? And what about vaccinations and those sort of things in rural areas?
So first I will talk about the telemedicine scenario and how it is impacting or contributing or challenging family medicine. So telephonic consultations were already in common practice, but this was not reimbursed largely. It would be normal courtesy calls and calls with your friends and the patients who know you, but mostly these were not reimbursed, and the culture in general was to go and meet your doctor as everywhere else in the world till recently. But because of this pandemic, several things have changed dramatically. Already for past 5 or 10 years, there were private companies which were contributing, developing networks, platforms, digital tools for telemedicine consultations. And as long as in 2015, when we had our second conference, one of the telemedicine companies, Practo, sponsored our conference. So even 5 years back, there were interest from the industry, from the IT sector into family practice. So they supported us and we partnered. So we take it positively. What is happening now after the COVID, we take it positively because largely it improves, because although it is important that we have employment for doctors in the government sector, but largely physicians have to or will have to work in private sector also. So in that situation, telemedicine regulations have been revised in India. Earlier, digital prescriptions were not legal in India, but on 24th of March 2020, we had a meeting with Prime Minister of India. It was a virtual conference. And during the pandemic lockdown time, it was a requirement and it was requested in that meeting that we all are ready to help digitally, virtually. And if this regulation is changed, if it is legalized, then it will be of great help for the doctors as well as the communities. So immediately within 1 week, Medical Council of India was instructed and they legalized and they released a guideline, which is telemedicine guidelines of Medical Council of India. You can search it and find it on website, and it is a legal. And now it is a commonplace for all doctors. And through 5 months after the that lockdown, I was myself seeing all patients on telemedicine tools myself. I am completely working as a private practitioner in the outskirts of Delhi, and I founded a company which is called Doc24, Doctor on Call 24/7. And large component of this, my clinic practice is also digital practice. So I'm working on digital applications myself, and it is advantageous being in India because these are not very expensive tools. And I also have plenty of other opportunities, at least 5-6 good products or services, and many new digital monitoring tools, equipments are all coming. So, it's going to become a commonplace. It is going to be future. Better we align to this, change rather than trying to resist ourselves or, trying to keep ourselves out of it or trying to say, no, this is not my game or something like that. My advice for family physicians would be to, move forward with the times. We are living in the time of Elon Musk, who is sending, he's talking about space travels, he's talking about, hyperloop travel, who's talking about petroleum-free transportation system, solar-based energy. So that is how the future is going to be. So we as family physicians or care provider cannot keep ourselves aloof out of it. We have to be part of the solution and we have to be part of this development. So that is one, telemedicine. Number two, about vaccination. Again, we are fortunate that in India, we already have very huge capacity of vaccine production. The total production, world production of vaccines was already done in India. 60% of the vaccines across world are produced in India. And at least 5, 6 companies started researching on vaccines. And we are currently the Covishield and Covaxin, 2 vaccines are being launched. And this is of very low cost, almost $3 US dollars. And the plan is to cover 300 million people in few months. Around 3 to 4 million people have already been given vaccinated. So far, this has come as a big relief because the whole big country was under lockdown. It will help us, develop confidence into businesses, opening schools, service sector. So, I mean, it was a challenge during the lockdown. It was a huge, big challenge, but now it has come. The vaccines have come as a big relief. And so far, people are taking it positively. Everybody is welcoming this. And unfortunately, we have capacity to fulfill the need of the population. So hopefully, and not only just within India, but because there are requests from outside India also. So government of India has already sent free, around 2 million vaccine vials to Bangladesh, around 500,000 to Bhutan, around 1 million to Nepal. They've all, shipped free of cost to the, healthcare workers of these neighboring countries. And I'm sure, I mean, we will overcome. I hope by, end of March, in Indian scenario I am talking about, we will be opening up most of the things. Practically, it's already open. There is no lockdown anymore anywhere in India. And I hope that helps in many parts of the world. We have second waves and new strains in few countries, but largely, I'm sure in a couple of months we'll have normalization of situation. By March, April, May of 2021, it will be absolutely normal. This is my understanding for what is going on in India. Thank you. Bruce, you are mute. Please unmute yourself.
I'd unmute. I thought I'd unmuted. My apologies. Raman, thanks for that. I wonder in the last few minutes if you could maybe summarize 1 or 2 things that you think are the outstanding achievements that you've made in India. What are the things that have made most difference? And what are the things that you think are the next big steps? Is it in education? Is it in remuneration? Is it in recognition? Is it in some policy or whatever? What are the things that you think, what's made the biggest difference and what's needed now to make the next steps for you in a country like yours?
So 2 things from the family medicine perspective. Most significant is inaction of the new law, new regulator, the National Medical Commission. The earlier one, which was a monopoly of specialist doctors, was a barrier to development of good quality primary care or family medicine. There was not a single family physician represented there. We did not have any representation anywhere on the regulatory framework. So, and that is an act of parliament. So if you look at the act of parliament, family medicine is the only discipline which is mentioned in the act. I mean, this is unique anywhere in the world which we have achieved, because when it becomes a part of act, if it is violated, it is legally binding on any government. Governments may change, new political party may come, new prime minister may come, but the act will remain and it is binding for implementation. So that is a very significant achievement for us. It will have a huge impact in near future. Second achievement was establishing a good robust journal of family medicine and primary care. And as I said, we were not focused on the terminologies of family medicine. We did not have enough academicians or academic centers to produce research. So we were flexible in allowing the research of other disciplines. So if you look at our journals, we allowed people from other specialties and discipline to submit and get their papers published. So that journal in itself has become a huge advertisement and a tool of advocacy and kind of acceptance of family medicine as a discipline across medical professionals as well as the academic centers. In our journal, almost all medical colleges, all medical schools, which are around 500, have published in our journal so far in last 10 years. All of India, from north to south, from east to west, and all their senior faculty, professors, so they own it. And all these medical faculty from other disciplines have contributed to the development of family medicine in a way, because they have shared their own research work, their own research material in our journal. And because we were a new journal, we did not have any barriers of any university structure or hierarchy, and we were free to move forward. So when we started our journal, we were publishing 2 times in a year, but at the moment we are publishing monthly issues. So publishing a journal and being flexible with the research work of other disciplines and let everyone participate into this process was another success. So discipline has made us rather famous in India. I mean, journal has made us very popular in India, because everybody has published, and they say that I published in Journal of Family Medicine in India. I mean, there are people from microbiology, there are people from public health, there are people from internal medicine, there are people from pediatrics, and that really helps because they accept it that this is a postgraduate discipline. So these two are important things. What would be transformative things for future? In my understanding, apart from this, what government does and what medical schools and medical education system does, what as professionals we do is most important thing. For example, I was working in a government system and I could to become an entrepreneur. And I'm working on digital IT sectors. I'm working on developing more academic forums, and I'm doing all these things privately. I'm not affiliated to any university or any institution anymore. We need new enterprises. And this is possible and in our situation, because we are a private, we are not dependent on government funding, and we have to think, we have to create. So entrepreneurship can be not just of financial type, but entrepreneurship in academics, entrepreneurship in professional development, entrepreneurship in research, entrepreneurship in setting new forums, entrepreneurship in setting new dialogues. All this will be transformative, and we are trying to translate and imbibe this into newer generation of our colleagues, our leadership pool, so that people understand that we do not have to depend on the system. We have to contribute to the system. We have to develop it to optimize it, and not wait that not be just blaming that this is not happening, that is not happening. We have to develop it, and we have to pass on the benefit to the future generations. I mean, this is very philosophical, but this is what I see would be transformative in India.
Thanks, Raman. It's actually inspirational. So that's great, and it's great to see your energy in moving all this forward. we are, we've traditionally with these gone to the hour and a half. I think we're just there now. So look, thanks very much for an inspiring discussion. Thanks everyone for your contribution. I think this is a really important area in the future for so many people in rural areas around the world, that we actually help as a group the countries who are bringing family medicine to their systems to do that. Next week, we've got epidemiology and public health. It's very topical at the moment, obviously, with the COVID-19. And then the week after, we'll have rural seeds again, and then on to our closing ceremony, which will be on a Sunday, not a Saturday. So we look forward to you joining us for that. So thank you very much once again for everyone's contributions tonight. And we look forward to, well, tonight, my time, morning, Jerry's time, and in between for everyone else. So thanks all, and wish you a good night. We'll look forward to catching up next week. Thank you.